4. Pre-pregnancy care, prenatal screening and fetal medicine. Pre-pregnancy care. To optimize the chances of a healthy baby, mothers are advised, attend clinic for prenatal care. Avoid or cease maternal smoking, alcohol, drug misuse, medication, unless essential, prior to conception. Toxoplasmosis exposure, avoid eating undercooked meat, and wear gloves when handling cat litter. Listeria infection, avoid unpasteurized dairy products and soft-ripened cheeses, for example, brie. Folic acid supplements preconceptually to 12 weeks, to reduce risk of neural tube defects and cardiac malformations in countries without folic acid fortification of foods, as in the UK and Europe. Higher dose if previous baby with neural tube defect. Avoid eating shark, swordfish, marlin and limit tuna as high levels of mercury. Limit oily fish as contain pollutants. Optimize management of pre-existing maternal medical conditions such as diabetes and hypertension. Pregnancies at increased risk of fetal abnormality need to be identified. Previous child with congenital anomaly. Family history of an inherited disorder, consanguineous. Parents known carriers of an autosomal recessive disorder. Parents from ethnic group with specific risk, for example, Ashkenazi Jews, Tay-Sachs disease, a neurodegenerative disorder. Parent with known balanced chromosomal rearrangement. Prenatal screening. Maternal blood. The routine screening tests vary geographically, but include maternal blood group, antibodies against rhesus, D, and other red cell incompatibilities. Hepatitis B, surface and e-antigen status. Syphilis serology, rubella, HIV infection. Screening for chromosomal anomalies, see below. Hemoglobin electrophoresis. Ultrasound. Ultrasound screening is recommended for all mothers before 20 weeks. Usually involves 2 ultrasound scans, a late first trimester scan, 11 weeks to 13 weeks 6 days. A mid-trimester scan, 18 to 22 weeks. Ultrasound screening allows gestational age calculation, optimal at late first trimester scan. Multiple pregnancy to be identified, number of fetuses and the chorionicity, number of placentae and amniotic sacs. Structural malformations, up to 80% of major congenital malformations can be identified. Screening for trisomy 21, Down syndrome. First trimester, nuchal translucency measurement combined with serum maternal hormones. Second trimester, for fetoplacental and maternal hormones in serum, adjusted for maternal age. Confirmed on amniocentesis or chorionic villus sampling. Detects about 90% with trisomy 21, but 3 to 5% false positive rate and 1% risk of fetal loss. Non-invasive prenatal testing, NIPT, fetal DNA from maternal blood for trisomies, rhesus, gender. Fetal growth monitoring, biserial measurement of fetal head size, biparietal diameter and head circumference, abdominal circumference and femur length. Amniotic fluid volume assessment to identify, 1. Oligohydramnios, may result in pulmonary hyperplasia and limb and facial deformities, 2. Polyhydramnios, associated with maternal diabetes, fetal bowel obstruction, CNS anomalies, and multiple births. Doppler ultrasound measurement of flow velocity waveforms, maternal and fetal circulation, if indicated. Screening, Group B streptococcal, chlamydia, cystic fibrosis. In US but not UK. If at high risk of cystic fibrosis, a panel of common gene mutations is used. Examples of structural malformations identified on ultrasound, figures from 4.1 to 4.3, see videos, fetal echocardiogram 1, fetal echocardiogram 2, fetal myelomeningocele, figure 4.1, increased nuchal translucency associated with trisomy 21, Down syndrome. Figure 4.2, sacral myelocele. Courtesy of Dr. Venkat Raman. Figure 4.3, Talipes equinovarus. Fetal medicine. Fetal medicine, Figure 4.4, may allow identification of congenital abnormalities, structural and chromosomal, with varying specificity and sensitivity of detection. Therapy, either indirectly or directly, to be given for a limited but increasing number of conditions, e.g. fetal arrhythmias, intrauterine blood transfusion for severe rhesus disease. Optimal multidisciplinary discussion to impart information on prognosis and allow parents to make informed decisions, including option of termination of pregnancy for severe disorders. Optimal obstetric management of the fetus, for example timing of delivery. Neonatal management to be planned in advance, for example counseling and transfer to specialty center. Figure 4.4, techniques in fetal medicine and their indications. Imaging. High-definition ultrasound. Fetal MRI. For identification and delineation of fetal abnormalities. Amniocentesis. Chromosome microarray and DNA analysis. Fetal infection, PCR, polymerase chain reaction, for CMV, toxoplasmosis, rubella, parvovirus. Non-invasive prenatal testing, NIPT. Free fetal DNA obtained from maternal blood for identification of fetal gender, for X-linked disorders, fetal genotyping, rhesus, and exclusion of common aneuploidy, especially trisomy 21. Likely to become increasingly refined and available in clinical service. Debate if should be offered alone or with nuchal translucency ultrasound screening. Ultrasound transducer, fetoscopy. Fetoscopic laser ablation for fetal transfusion syndrome. Fetal blood sampling. Fetal hemoglobin for anemia. Fetal infection serology. Fetal blood transfusion. Chorionic villus sampling. Chromosome microarray and DNA analysis. Enzyme analysis for inborn error of metabolism. Preimplantation genetic diagnosis, PGD. In vitro fertilization, IVF, allows genetic analysis of cells from a developing embryo before transfer to the uterus. Fetal surgery. Creates media headlines as cutting-edge technology. However, the results are generally poor as the malformations justifying fetal surgery are severe, and the risk of premature labor is high. Now practiced only in a few centers and mainly restricted to randomized trials. Cases must be carefully selected. Open fetal surgery. Randomized trial, MOMS, for myelomeningocele showed fetal surgery after hysterotomy, uterus opened at 19 to 25 weeks gestation, reduced the need for shunting and improved motor outcomes at 30 months. But uterine scarring and increased risk of preterm births. Fetoscopic minimally invasive fetal surgery. Fetal endoscopic tracheal occlusion, FETO, for congenital diaphragmatic hernia. As fetal tracheal obstruction promotes lung growth, this is replicated by inflating a balloon in the trachea, inserted at fetoscopy. Randomized controlled trial, TOTAL, shows slightly improved lung function in infancy though increased rate of preterm delivery and survival not improved, see Chapter 38. Catheter shunts. 1. For fetal pleural effusions, usually a chylothorax, lymphatic fluid, inserted under ultrasound guidance, figure 4.5. Reduces risks of fetal death from hydrops and pulmonary hyperplasia. Neonatal course often satisfactory. 2. Congenital bladder neck obstruction, vesicoamniotic shunting. Controversial. A randomized controlled trial, Pluto, showed shunt improved perinatal survival but did not reduce morbidity from renal disease or death at 2 years.